Hello everyone, this is Piyush Vinchurkar and I am a third year MBBS student. I am participating in PK Fin Forum Presents National Clinical Case Presentation Competition. So let us see what my case is. My patient is a 52-year-old male. He presented with the chief complaint of severe chest discomfort since 3 years. The patient says that he was apparently alright 3 years ago and he woke up with a pressure sensation and chest discomfort which it describes as severe in intensity. The patient has no history of radiation of pain, no difficulty in breathing, there is no history of collapse, palpitations, cough, fever, or trauma. The patient has only a medical history of hypercholesterolemia. Also, the patient reports that he has addiction to smoking and that is 40 pack years. On examination of the patient, the pulse rate is found to be 116 beats per minute. The blood pressure is found to be 166 by 102 mm of Hg. The respiratory rate is found to be 22 breaths per minute. Oxygen saturation of the patient is 96%. The JVP was normal. On auscultation of the chest, bilateral air entry is present. F1, F2 sounds are positive. There is F4 gallop. Murmur is negative, and also the pericardial rub is negative. The chest X-ray shows bilaterally clear lung fields and also normal cardiac phenotype. ECG shows FT elevation in B1, B2, and B3 leads and tall T wave in B3. Reciprocal changes are seen in lead AVF. Let us see what are the differential diagnoses are. Now, whenever a patient of chest pain comes to the emergency department, the top two differential diagnoses are the one which is more common as compared to myocardial infarction, that is an episode of gastroesophageal reflux disorder, and second, which is more dreadful, that is myocardial infarction. However, clinical findings and ECG definitely rules out the acid reflux. So, other than MI, the DDs which should be considered after seeing chest pain and FT elevation in ECG are aortic dissection, acute myocarditis, acute pericarditis, and acute pulmonary embolism. For this case, the most probable diagnosis is STEMI, that is FT elevation MI. Let us see how I reached to the diagnosis and ruled out others. Well, this case was a case of STEMI, but the points on which are ruled out are first, aortic dissection can be ruled out as there is no murmur of aortic regurgitation, there is no syncope, there is no hypotension, no neurological deficits are seen, no asymmetrical pulses are seen on examination, and it can be confirmed by doing a CT chest and abdomen with a contrast. Acute pulmonary embolism can be ruled out as there is no significant dyspnea that the patient complains of. There is no hypotension, no syncope, no JVP elevation that is features of heart failure, and no loud P2 on auscultation of heart sounds. Acute pericarditis can be ruled out as there is no fever, no symptom of aggravation of pain on deep breathing, which is a cardinal symptom of acute pericarditis. There is no pericardial rub. There are no signs of heart failure, and there is no hypotension. Acute myocarditis can be ruled out as there is no history of fever and there is no history or sign of any connective tissue disorder. We know that acute myocarditis is a very rare disorder and 50% of the cases have viral fever in their history. Secondly, they may come with connective tissue disorders, but in this case there is no feature of that also. And also there are no signs of heart failure. So this case is a case of FT elevation MI, and therefore the treatment includes aspirin 325 mg chewable tablet, ramipril 2.5 to 5 mg chewable tablet, atorvastatin 80 mg so as to reduce the inflammation, clopidogrel 300 to 600 mg. Oxygen can be given to the patient 2 to 6 liter per minute. Morphine can be given for pain 2 to 4 milligram IV. Nitrate infusion so as to decrease the blood pressure 10 microgram per minute, and metoprolol IV again for stabilization of the heart. The definitive treatment includes the percutaneous coronary intervention. So, if the unit has a PCI unit, then PCI can be performed. However, if the unit doesn't have the PCI, in such a case, the patient can be shifted to another hospital which has a PCI unit. And only if the travel time between the two centers is less than 120 minutes. If the travel time is greater than 120 minutes, in such a case, thrombolysis can be performed in the same center with the help of alteplase, which is a recombinant TPA. Thank you, everyone.